Thank you, Adam.
Hi, hello everybody. I'm Alison Clements and I'm not an analyst, but really great to be in a room full of them. So we're here to talk about why modelling of inpatient discharge predictions is key to reducing ED admitted delays, and sometimes we have to cancel electives because of that. And this is an example from University College London Hospitals. And Zella.
So yes, Alison is the head of operations at UCLH, and I am a health data scientist in the clinical operational research unit at UCL, and also an embedded researcher at UCLH. I came to HACA last year. Craig, our colleague here, and I put a paper in. I presented it. I came back saying, I think this conference is really cool, and so I'm really happy that I'm here, not just with Alison, but also Craig, Sally, Lorraine, and Claire here as well, all from UCLH. We're very happy to be able to share what we're doing with you. So Alison's going to talk a bit about her challenges as an operations director, and then I'm going to talk about some modelling that we're doing to support her decision making.
So hands up in the room who's not an analyst and who's trying to run the hospital with support of analysts. Okay, just a few of us then. So what are the challenges for people like me and a few of you in the room? It's about trying to manage patient flow with extremely constrained systems. We need information to support decisions about when patient care is safe or unsafe. We need information to support escalations, both internally and sector-wide. For example, do we need to ask to divert ambulances away from us? And the worst case is we have to cancel electives to fit our emergency patients in. So to do our job, we need a solid picture of capacity and demand and those imminent pressures. So we need a current situation, we need future expected discharge information, future expected admission information, and future short-term challenges due to that mismatch of admissions versus discharges. Flow huddles, which is what we do at UCLH, and driving change through data helps us to get to a better position to run the hospital. We have a great electronic patient record system, EPIC, which has an integrated bed management module. But we still need to invest in a lot of manual data curation to understand our current position. So, for example, we do a manual outlier report every morning, and we have 5 times a day flow reports that are basically manual data entry with a bit of automation. And that's an example of one of them that we utilise to help us understand what the shape of the hospital is. The problem with a ward level approach, which is what we tend to provide to our customers, for want of a better word, our clinicians and our other ops managers, is it's difficult for specialties to see their changing footprint, which includes numerous things. And the list there is complex. It's about patients on a specialty's home ward. It's about those that are sitting outside of their home ward. Those that are in our acute medical unit needing, onward transition to a specialty bed. It's patients waiting to step down from ITU. It's patients in theatres, in clinics that need emergency admissions. It's patients with a decision to admit in ED or our same-day emergency care unit. Incoming demand from patients currently in ED prior to a decision to admit. So those patients on ambulances sitting outside, they're not ED patients, they're a specialties patient ready to come in. And then the incoming demand from patients yet to arrive. Trying to put all of that in one place for someone like me to understand, let alone the specialties to understand and have a grip of, is really difficult. So could we do more, given our capability in real-time predictive modelling? So we have a vision to be proactive about our emergency patient capacity needs. And we're using the emergency patient here because we've got a massive project at UCLH looking at how we can improve our emergency pathways, but the same would be for an elective patient pathway. So to enable this vision, we need a rolling picture of each specialty's changing footprint in the hospital. And that changing footprint is the current occupancy, and it's that incoming demand, and it's the forthcoming departure, so the inflow and the outflow. This rolling picture will help us to anticipate whether each specialty will have an increased or a decreased footprint in 8 hours' time. And it means we can track each specialty's position relative to its agreed bed base, its home ward, its funded bed base. So having this rolling picture means we can work with specialties to deal with imminent pressures for their bed, so really locally own this problem. We can take targeted escalation actions when pressures look like they might be hospital-wide, but also have more confidence about not escalating. So we're trying to be illustrative here about how difficult and how complex it is to really try and understand where are those specialty patients. So we're using gastroenterology as an example. So where are they in our hospital? Well, some of them are sitting on their home ward. So in this example, gastro has capacity of 16 beds, and currently 15 gastro patients are sitting there. We've also got gastro patients on 2 other wards in the hospital. We've got them on acute medical unit, an ITU, waiting to transfer to that home ward. They're in theatres or an emergency clinic, and one's in the emergency department. So just looking at all of those facets, I can immediately see I've got a -6 position for the incoming and the current occupancy of our gastro patients. So what can I expect a bit later? Because I always want to horizon scan, as I'm sure most ops people do. So I've potentially got 2 more patients in ED and SDEC, and gastro tell me they've got 5 patients that they're planning to discharge today, or not. So then that footprint's slightly bigger, but I've got a bit of outflow, got a bit more inflow, and I'm now looking at potential -3. So I've got this -3 position to midnight, but I'd like some actionable insights for a rolling 8 hours, and we can't be certain about all of those numbers.
Thank you. As Alison says, we can't be certain about any of these numbers. So maybe 5 patients will leave gastro by midnight, but perhaps it could be a smaller number, and maybe the number arriving later could be larger. So possibly Alison might be sitting looking at a worse deficit later, in which case then it probably would be sensible to take some escalation actions. But it's equally possible that the situation could go in the other direction, and as Alison said earlier, not escalating might be fine. So what I'm going to talk about is some of the modelling that we've done to enable this kind of overall footprint. And just to give a sense of the sort of dynamic nature of this information, I've got this diagram here showing, as a progression over the day, what is known to Alison and her team about a group of patients. So they're divided, they're flowing based on whether at any point in the day when they're observed, they're thought to be not leaving today, query discharge for today, confirm for today, or eventually having left. And you can kind of see that at 6:30 in the morning, you've got a bunch of people who at 6:30 weren't thought to be leaving, and then you've got a bunch of queries. And then as the day progresses, you see some people coming down from the not going position, heading towards discharge. But equally, you're seeing other patients who are going from queries and they end up not going. And those are understandable shifts because, of course, ward round happens and clinicians are reviewing patients for their suitability for discharge. But there's also a lot of other background aspects of the discharge process which makes it complex and hard to predict exactly who's going when. And it's this dynamic picture that makes it very difficult to understand, of the 5 people gastro said they were going to a discharge, how many of them are actually going to go. So a common approach to this uncertainty that many trusts take on the discharge side is to apply some kind of percentage to the queries. So if we say that, and this is what we do at UCLH, well, let's assume that 80% of the queries are going to go, so that would be 80% in this case of 4 queries, and let's assume that all of the confirmed discharges go, and then that'll give us some sense of whether our 5 is a good number or not. And then on the admission side, it's quite common to use like some benchmark of like yesterday or the last 6 Tuesdays, if it's Tuesdays, as a sense of how many people are going to come in. But given that we've got EPIC and we've got the capability to do real-time predictive modelling at UCLH, we can do more. So I'm going to suggest a different way, taking into account these kind of, the idea of uncertainty and trying to get a better handle on, is it really going to be 5 people leaving? How many more beds can Alison and her team expect later on? So for each gastro patient, we want a probability of each of them being discharged. And as Alison said, she'd like an 8-hour rolling picture. So ideally, we'd be able to do this not just till midnight, but in the next 8 hours. And there are lots of signals in the notes that we can use. So if I express it a bit more formally, we can think of a probability of any patient in gastro being discharged from there within 8 hours after the time that we observe them. That's going to be a function of the time of day, of the day of the week. For example, a lot of discharges happen on a Friday prior to the weekend. The fact that a patient has a confirmed or query discharge is going to be an indicator. There's a safe discharge patient assessment score that gets recorded on admission, where a nurse will really try to understand the patient's home situation, the nature of their home, and the complexity of their discharge process later on. And that kind of information is also captured in their discharge to assess pathway, where patients on pathway 0 are assumed to be discharged to home, so they're going to be less complex to discharge. And then patients on pathways 1, 2, and 3 are more complicated, potentially ending up in funded rehab or care home beds, which may be very difficult to secure. So there's that information, there's length of stay information about how long has this person been here, and there's other signals like the level of staff activity around a patient, and signals potentially within the notes as well. And you'll notice that if you've looked at some of the other work on predicting length of stay or predicting discharge, it's often using physiological, clinical signals. I'm not talking about those here, I'm talking about operational signals of activity and information about the patient. So if we can build up now a probability of each patient being discharged in 8 hours, then we can use some probability theory to then generate a distribution over the number of beds. So let me just explain what this chart is showing. So earlier, we knew that we had 23 gastro patients in the hospital, so the x-axis goes from 0 to 23. We're not likely to have all 23 of them leave, but equally, it's very unlikely that 0 will leave. So what's the most likely number of patients who will leave? Based on these signals that we've picked up from the data, well, this chart suggests the highest bars are at 11 or 12. So actually, there's a good chance that as many as 11 or 12 will leave. And I've drawn some dotted lines on the chart as well. So that's if we wanted to be a bit more conservative and wanted to be really quite sure of a number of patients who will leave, we could say with 90% probability that at least 8 patients will leave. We could say with 70% probability that at least 10 patients would leave. So that's starting to get some kind of quantification of the uncertainty around how many patients will go. And that then we can feed that back into our sort of calculation of the net position at the end of the day with more sort of information around those predictions. And we can do the same on the admission side. And indeed, we've already done that at UCLH, and we have models running, making these predictions on the admission side for both the ones in the emergency department already and a prediction for the number who will arrive within the next 8 hours and be admitted, assuming that the ED is meeting its 4-hour targets. And then we can bring those two distributions together to get a sense of what's the net change in 8 hours likely to be. And so here from this lower chart, we're starting to see that the most likely net change in 8 hours, the highest bar, is actually at, what is it? Oh, sorry, it's like at 8. So it looks like the number of beds in the next 8 hours is going to be trending towards a more positive change. And again, we can apply a more conservative kind of approach and say, well, let's not go with the expected value. Let's be a bit more conservative and say with 90% probability, we think that the position in 8 hours' time will be at least 2 more beds free. And then we can then relate that back to the agreed bed base for gastro, which was 16, and see that actually, okay, we're probably looking at a -4 with 90% probability that the position will be no worse than that. And what this is doing is it's giving a much more precise picture at specialty level about what the position is likely to be. And that gives Alison and the team the ability to talk to clinicians in that area of the hospital about the pressures on them in the short term and decide when and how to take action. So this is what we're working towards. Some of the challenges in this work that will be very familiar to you. I mean, the realities of hospital life are very difficult to capture in data. There are delays that we can't really observe, like delays to patient reviews. There might be reasons why we're not seeing any data around a patient, but actually something very important clinically is happening. We can't obviously observe all of the complicated sort of downstream social care package type information that would be a genuine impediment to people leaving. And as I've already shown, the data around a patient rapidly changes as the day progresses. And then even in the data that we do have, the challenges are sort of establishing what is an agreed bed base, and of course beds open and close, escalation beds are available. So understanding that and how patterns of bed base have changed over the course of the modelling period that we might be using, that's something that is a headache for the analyst. Retrospective data entry is a challenge, so always trying to understand when the data was actually known as opposed to when it might be retrospectively updated about, for example, discharge date times are often retrospectively entered. And when we're doing this kind of thing real time, we would ideally have a full picture of every piece of data about a patient in real time, but that's rarely achievable. So we might be looking at data up to midnight last night for doing this modelling, which will limit what we can do in the later part of the day. And then, of course, probability distributions are not for everyone, and I think one of our challenges now is to understand how we can use this kind of approach with Alison and the team, and also make it accessible both to them and also to the clinical specialists, such that if you, perhaps a clinical specialist would like to see a probability distribution, but perhaps a single number would be more easy to communicate. So we're kind of working through how do we convey this information in a way that's true to the modelling, but is also accessible for people. But returning to our vision, this is what we're working towards at UCLH, this rolling picture of each specialty's changing footprint with both the accurate view of the current occupancy and then also this picture of flows in and flows out. And that means we can identify areas of imminent pressure, as Alison said, and ultimately, while this is useful for the team and for operational aspects of the hospital, it's really for patients and clinicians because it means that the emergency provision will be there for them when they need it. There's a few things, if you're interested in finding out more, there are a few things that you can refer to. So I recently did a webinar hosted by the NHS-R community talking about how to turn your EHR data into predictions of demand. So I don't cover the discharge side in that. And then I came to HACA last year and I discovered about reproducible analytical pipelines, which I'd never heard about before. And I became more and more determined that we could share our code with other trusts so that other people can see what we've done. So there is a GitHub repository. It's called Patient Flow. There's a link on the next slide as well. And it's quite exposing to put your code out there, but it is out there. It's definitely work in progress. And there are both notebooks and it is Python code. There was a bit of a deliberation about that at the beginning, about which, but we've gone with Python for now. And I'm going to be talking more about that at the Python R showcase this afternoon. But I'm really happy to say that UCLH has agreed that we can share real patient data with you as well. So we've got, it's all anonymized, and we've taken out minority individuals and so on, and dates have been shifted into the future. So it is not possible to identify anyone from this data. So we've got that we can share if you contact me, and then we've also got a synthetic version of that data set, which I'm going to put as part of the GitHub as well. One of my colleagues at UCL has developed that. And then we did write up the modelling of the demand side in an academic paper as well, if you're interested. So thank you very much for listening. We're really happy to hear from you. Our colleague Craig has done a lot on this as well. He's here, as is the rest of the team from UCLH. So yeah, we'd love to hear your questions.
Thank you. again, lots of questions. We're going to try and get through 4, which we've grouped in 2 sets because they're quite related. So if we take the first 2.
Okay. Has the fact that this data is visible and being used to improve the quality of the data, for example, more realistic about expected discharges, forecast becomes closer to reality, potentially reducing 80% and a more accurate model? Second one, I really support the idea of looking at flow through a specialty approach. Are there plans to broaden this to include community capacity, such as virtual wards, to move specialty care outside the walls of the hospital?
So I think this is about expanding the model for other uses, and it might be too early to be thinking about that, but can you use it in other parts of the system? And crucially, we know big challenges around discharge. Are there learnings from this to actually be able to do some more discharge in a different way to solve that big gap, I guess, is the root of the questions. But someone will correct me if I'm wrong.
I'm sure there will be, is the answer. I
Okay.
think the richness of data that we can get and look at, I'm sure there will be. And really understanding about what those key words that our clinicians put into our electronic health record system that indicate that this patient is going to go home, but they haven't put a confirmed discharge order in, which is the official way of dealing with it, helps us to understand actually more patients are on the discharge pathway. And the team in front here we call them Mrs. Marple. So my team in front here, when we're having our flow meetings and someone says, oh, there's an expected discharge date, Mary's going, but doesn't look like they are, and then being able to go into the health record to find a note that a clinician has said, yeah, they're going to go home after X, and being able to delve into that in real time to really confirm that that patient's going home is amazing. So I think the more, and we're working with clinicians about doing smart phrases so that easier stuff to get out, to be able to better understand the predictability of our discharges. So I think definitely it's going to be, the future's bright.
The benefit and the challenge of that is if you bravely shared all your code, so people can take that challenge away and they can take your code and adapt it for other settings, community, intermediate care or virtual wards, whatever, and then be sharing that back in community.
The one thing I would say about that is it is really intended to be short-term demand or discharge modelling. So when you're thinking about the sort of community settings, thinking about things in 8 or 12 hours' time is not necessarily that useful.
When you're measuring with days rather than...
Yeah, exactly.
Okay. Fair challenge. Okay, we'll take 2 more, which that's kind of led into. But Jane, want to come up and start setting up? Is Jane here? Yeah. Do you want to come start setting up? Great. Next 2 questions.
Okay. Has this rate model already been piloted successfully? If so, who are the main users of the database? Would it be ward managers and bed managers, or used mainly on ED trackers? Any anticipated issues with training for using this model? And is there a tendency for managers to act on pessimist projections but not to act when projections suggest an easier position, i.e. they use the projections to protect resources but not to release them?
So again, who's using this, and then how good does the modelling need to be to convince them to use it?
I mean, we're using it and using it more and more, particularly the admissions work that we've already got in place. And the discharge one we're still working on, as Zella said, we haven't got that ready yet to utilise and put into operations. But I think the second question was about how much of it do we trust, if I don't get that? And I think...
How much you trust, but also how good does it need to be to build that trust?
So we've been working on this 80% of trusting what goes into the system in terms of expected discharge, and that seems to work, but we'd like to be better. We obviously want to be more accurate all of the time. So I think we can live with a bit of, probability and prediction, but the more we work with Zella and others, the more hopefully we can get to more accurate predictions and not escalate unnecessarily, which we tend to a little bit get criticised for. We put out something that we're on a red bed alert, come on, everyone's got to go and do stuff. But actually, if we had better data and better predictions, we'd do that less, and obviously that'd be better for everyone.
Can I ask, do you have, off the back of this, any patient, you start to build patient stories of how this approach has improved the speed at which people are getting into a bed in the first place and improving that flow?
So we haven't yet. We tend to do our patient stories on when it's bad. To just say, come on, we've got to make it better. But I think it's a really good thing, and we should do, because the power of the narrative is really good to get messages across.
Because you want more and more people buying into this model, but this approach. The more positive patient stories we can have. We do have a couple of minutes. If anyone's got a burning question they want to ask, or yeah.
One of the things you said was
Sorry,
that
do you mind introducing yourself to the room and then?
I'm Steve Black.
Yeah.
So it's I have worked with several who did into what we've got and I've tried to improve things in hospitals all the time. One of the things you said was that you have a problem having reliable data, and some of the problems are about manual data entry or data entry being delayed. Have you considered putting in real-time patient tracking so you don't need to do manual data entry?
Yes, and we actually had a real-time patient tracking system before we went to Epic. We used teletracking. I don't know whether people have heard of that. So we did have little wristbands on our patients. We didn't do full bed level tracking. Actually, the sort of the benefit didn't, wasn't cost effective for that. But having a little tracker on a patient, we put that in a Dropbox where the patient left the ward, and that read the wristband, made the bed dirty, automatically sent for the bed cleaner. But what happened is, patients left the ward with their wristband, so we lost hundreds. And the nurse took it off. I don't want the bed ready yet because I really don't want another patient, so delayed putting the wristband in a Dropbox. So we all thought it was going to be magical when we first put that system in, and it wasn't as magical. So there's still human intervention, and if that nurse is busy and really doesn't want their bed to be declared dirty and cleaned because they're just, they're too tired, whatever, then it doesn't work. And I think, but I'm happy to be told otherwise and have other systems, to look at, but at the moment, no.
Good answer. Thank you. Thank you very much. I'm afraid we'll